Welcome to the Heart of It, where we take you to the heart of healthcare. This season, we're exploring what happens behind the scenes at Fraser Health to ensure patients receive the best care possible. Fraser Health provides care on the traditional, ancestral, and unceded lands of the Coast Salish and Inklakatma nations and is home to 32 First Nations within the Fraser Salish region. Fraser Health is dedicated to serving all Indigenous people and honors the unique cultures of the First Nations, Métis, and Inuit living within the Fraser Salish region.
Welcome to the Heart of It. Today I'm joined by Dr. Craig Murray, who is our co-regional medical director for Emergency Department, and Mary Van Osch, who is our leader for Emergency Medicine Network. So thank you so much for being here, and especially for the work that you do on a day-to-day basis, because emergency department services are such important services that we provide in our region for over 2 million people. And I think we see over 2,000 people on a daily basis in our 12 hospitals across the board. So not a small number of patients that we see. And I think one of the things that we want to do through this season is to kind of go behind the scenes in different services that we have at Fraser Health. And I think emergency department is probably the one that has most interaction with diverse people across all of our communities. So maybe to start off with, maybe I'll ask Mary to start with, what is an emergency department and what kind of services do we provide there?
Well, an emergency department should be an area where people are going for emergency care or more urgent needs that they can't manage within their family physician or an urgent care center. So it is really intended for that emergency in-the-moment care that we need to provide the people in our communities. So that's really the focus of what should be an emergency department.
And Craig, are there different services that we provide in emergency departments across the region, or are they pretty much consistent emergency services?
We have a baseline expectation of all departments to be able to see and accept all patients of all ages, pediatric through geriatric. But there are certain hospitals which provide even more specialized services. So if we think about trauma, for example, there's a center in the east, which is the Abbotsford Regional Hospital. They are a trauma center, as is our main trauma center at Royal Columbian Hospital. And then other services, for example, if you have an acute stroke or a heart attack that needs a cath lab, then you'll be seen first in the closest department and then taken quickly to the larger center.
I just want to add that I think it's important that everyone knows that the community where they live is the emergency department they should go to, because our hospitals work really well together in ensuring the right patient goes to the right place for their services. So despite the fact that some hospitals are more focused on different types of care, I think the doors are open for everybody 24/7. So
we really work as a network of hospitals and really as a network of emergency physicians and nurses and on the operation side.
So when somebody is looking at, do I need to go to emergency department or not, and whether it's for themselves or for their family members or loved ones, what kind of advice would you give?
in terms of accessing emergency care, I think first of all finding out if that's the best place for me to go, and there's a number of resources to support individuals now. We have on our Fraser Health website, Fraser, it's a front door that allows people to check out other options for care besides the emerge department. If it is in an emergency, you have severe chest pain or you have trouble breathing, absolutely the emergency department is the best place to go. But the less urgent issues, there are some other options. So there's different ways to do that. We also have a wonderful virtual care nurse line that's open from 10 to 10. And they're a registered nurse that's on that line that can help patients navigate where they should go for care. So it's another great option.
And we have a provincial resource, which is well known to most of the public, the 811 line, which they can call and ask for advice. And often we'll have patients directed from 811 services to our emergency department.
So lots of options in the community for people to be able to actually decipher where to best get their services. And then if, of course, as you said, chest pain or specific emergencies that are trauma or things like that, of course, you're redirected, whether through ambulances or otherwise. Maybe let's go through the ambulance first. If you're coming through like via ambulance and arrive at one of our hospitals, what does that triage process look like from ambulance to be seen by a physician? Maybe I'll start with Craig.
Well, if you arrive by ambulance, or it's the same if you arrive at on foot. There is a triage process. So the triage nurses are trained, and it may be physically a similar location, but we try and have ambulances arriving at a slightly different location. There's a triage process, which means to sort. So our triage nurses are highly trained to assess the presenting reason that you're in the emergency room, look at your vital signs and like your blood pressure and your heart rate and how fast you're breathing, and make a very quick determination of what your priority level is at the triage desk, and that's a level 5 through 1. So that's really how we sort through patients very quickly.
Yeah, and I can just add that ambulance and walk-ins are treated the same way, because we could have just as sick walk-ins walking through the door as they do, and that are more sick than the ones that are coming by ambulance. So the whole role of triage is to determine who's sick and who's not sick. Mm-hmm. And the sick ones are seen as quickly as possible, and the not sick ones may have to wait a little bit longer depending on what's going on in that department that day.
Yeah, and what I often hear like from feedback is that when people are really sick, they get kind of very quick, fast, and almost seamless care when they come through our emergency departments. And then sometimes when maybe they're more stable, otherwise it can be quite a frustrating process. So I think one of the things that people wonder about is there kind of like a general sense of how long it might take for people to be seen by a physician or nurse or care team?
There should be, in a situation where we've got normal staff levels, normal services, what's going on in the emergency department. Are we already dealing with really sick patients who require high-level critical care? If there's a lot of that going on, the waits could be longer. If things are at an easy stage and we've got good levels of staffing, it could be within the amounts that we usually indicate. So patients who come in that maybe have some stability, they have good vital signs. You're supposed to be 4 hours, but again, all of that, though, from front to end, from start to finish, but that all could change based on what's happening in the department at any given time. So lots of variables.
And from our point of view, even though you haven't yet seen the emergency physician, there's a lot of care that's already been initiated. We've worked collaboratively as a team to establish protocols where a patient that presents with chest pain or with abdominal pain will have blood work started at or shortly after triage, so that's in the works. We can do some imaging without having seen the emergency physician yet. So care is initiated, and then, as Mary said, in a perfect world, these things would happen with a certain time frame, and I think what you're seeing, as anyone would know, if you read the news or listen to the news nationally, there are very significant strains on emergency departments in Canada and on staffing, physician and nursing staffing. So we are seeing what the public, I'm sure, feels are longer wait times than we would like.
You mentioned, Craig, sometimes there's perception that you're only seen once you see a physician, but really your care starts right after that triage. So even though the perception might be that I'm still waiting to be seen, after triage, your care actually starts right there. So maybe some examples of what typically happens for some of the typical C-test 3, 4, 5 types of patients, because those are more of the patients that are more likely to wait, would be helpful.
Yeah, I think I would say up front that one of the great things about working in the emergency department is we work very much as a team, and we are in constant communication with the nursing side of it, and they will identify a patient at triage they have questions about, or vital signs have changed as we're reassessing, and then we're bringing in people up triaging them or making them a higher priority. So things will change rapidly, but we are absolutely working as a team, providing care together, and that starts right at triage, as you said, Victoria.
Yeah, and I think I can give you a good example is someone who's got maybe upper abdominal chest pain of some sort. They've got normal vital signs at the triage process, but they do have some history that leads to think it might be a heart attack. And so the nurse would enter orders for labs, an ECG and a chest x-ray, get all of that back, look at them, review the ECG, and then have a conversation with the physician. The physician hasn't even seen the patient yet, but that nurse is being the eyes and ears for that patient, seeing how they are, how they present, what happened. And if things are normal, within normal limits, that patient will wait longer to see a physician than one who maybe has some changes on their blood work or their ECG. So again, as Craig said, it's really important that that team, that physician and the triage and the charge nurses work really closely together to make sure the right patients get escalated care that need to, and the right ones that could wait a little longer without having any bad outcome. Those are the ones that need to wait a little bit longer, because there's always the one that is sicker that we need to deal with first.
Yeah, and if you're looking for a specific example, I think everyone knows about, for example, appendicitis. If you present with abdominal pain, there are scores of causes of abdominal pain, and we have to figure out what's the most likely, and that involves taking the story and then doing a physical exam and doing often lab work and imaging. So you will come in and get lab work very often immediately. Then the physician will see you after the nurses have, and you may have further lab work. You may have an ultrasound or a CT scan ordered to help with that diagnosis. But then you are in another queue for the imaging, for example, and the radiology department or diagnostic imaging is triaging which one of the requests needs to go next. So sometimes there's a wait for the next test. Or if we have imaging back and it confirms it's appendicitis, well, we need, or sometimes, especially if think of pediatric patients, it's not always clear on ultrasound, which is the test we use. We'll need to get a general surgeon down to assess you and make a decision clinically, and then that will take potentially time if they're in the operating room at the moment. So lots of little steps, and unfortunately sometimes they involve waits and they can compound, and it makes for a longer visit.
So it sounds like when patients come, whether it's by foot or by ambulance, you're triaged at the front door. Care in terms of care team coming together to look after a patient begins right afterwards, and that includes getting some diagnostics done, vitals, connecting back with nursing team, physicians, but there may also be a different physician than emergency department physician that needs to see the patient. So there's a lot of factors that go behind the scenes about how long it might take for you to be actually seen by a physician. But I think that is the part sometimes we get stuck on, because as you said, I think you began with this, that care actually starts right after triage, and there's so many different team members. And you've been doing a lot of work, Mary, in having a robust team-based care in emergency departments. Maybe you could talk a little bit about what that team looks like and what kind of roles different folks in that team play, and how I think, again, there might be frustration when you're waiting, but really that it's not just waiting for to be seen, and that's the only part of the care journey. The whole care journey actually is taking place there.
I think we've had tremendous challenges post-COVID with nursing shortages. Nurses have lots of options where to work now. We're short in every sector. We're short of nurses. So we've had to really be very creative in how we operate the team of nursing alongside the physicians that provide care to a group of patients. So most of our departments have what we call this Zone 2, which is an area for ambulatory patients who need to see a physician and hopefully most likely will go home. They don't really need a stretcher for long periods of time during their ED visit. And so that can really work well with a team approach. So the team means it could be a registered nurse, it could be a licensed practical nurse, it could be a healthcare assistant, it could be a unit clerk. They all work together to provide care for that patient, all to the top of their scope. So we've worked hard to make sure, working with our union bodies and our professional practice leads, to ensure what is within scope in this role, and let's educate them to get there. And so we've been very successful at stabilizing staffing at a number of sites with that team care approach. It can be a little more confusing for the public because they don't know who's a nurse and who's not a nurse. So we've kind of paralleled it with a family-centered care project where we really work on educating the volunteers and the patient ambassadors and our healthcare assistants to know how to speak to patients, let them know that who they are and that someone will be seeing them shortly, give them some comfort items, a warm blanket, a glass of water, things like that, really trying to embed that into our cultural practice as well in our emerges. So yeah, the team-based care, very important. So we've got an emerge qualified nurse. Maybe where we used to have every single one in the team was them. Now we may have one or two in that team, but they've also got other care providers, but they look to that emerge qualified to escalate any concerns or issues. And then that emerge qualified nurse will understand better when should I talk to a physician about a concern, and they can go in and do that assessment that they need to. So it's all depends on how well the team works together. So that's been a huge work for us in that team building. But we've been at some sites very successful, so we're quite encouraged by it.
And Mary, you mentioned nursing shortage, but sometimes in some of the areas like emergency department, it's worse than other areas because the work itself is so demanding and unpredictable. As you said, like some of the reasons why we can't say it's going to be exactly this amount of time for this or that, because we don't know what's going to happen, and that can be quite a challenging area of work. Some people love the adrenaline of it, but some people really get very, very stressed in that kind of role.
Yeah,
too.
and I mean, one of the challenges is nurses are working with patients who are admitted and are needing to go to inpatient units, but we have shortages of beds or lots of increase in acuity in our hospitals, and people who need to stay for a bit longer. There's no space we're at capacity in many units, so they end up staying in emergency a bit longer. And so our nurses are having to care for those patients as well as the ones that come in the door. So it is a very challenging environment. Nurses work very hard, physicians work very hard to manage the workload. And I think right now, today, that's our biggest challenge, is that additional workload that is in our emerge departments, with more people wanting care in the emerge department and other patients who need care not being able to find a better place to be positioned outside of emerge. So.
And Craig, we've seen an increased number of people coming into our emergency departments as well, and there's many reasons for that. What do you think are kind of the main reasons for having more and more people come through our emergency departments?
At a higher level, we have bigger population, particularly in Fraser Health. We have an aging population, so the demographics are not in our favor because that older population needs more care. And then there are other issues that are prevalent everywhere, and not just in Fraser Health, but in Canada and other countries where there are challenges with access to primary care, and so that is more acute in certain communities in Fraser Health, and certainly where we are located here in Surrey-Whalley area, that's a very significant problem. So lack of access to primary care is a major challenge for emergency departments. People are presenting for things that they could have seen their family doctor for or had a conversation with, but don't have access. And there are other services we put in place. You mentioned the virtual line, which is helpful. There are urgent primary care clinics in the community, which are a great idea in our communities. There has been a challenge with staffing those as well, so they're not, I would say, working at full capacity. So all of these things sort of culminate together and land up in the emergency department. It is really the front door for most people to the hospital, and we'd really like to educate people. We'd love to have other areas of the health care system working to full capacity as well, and so we could specialize on real emergencies. And I think when Mary talks about the challenges of the team in the moment, I think if the team were focusing on emergency care only, not managing inpatients, not managing issues that are probably more primary care, then we would, I think, have an easier time with satisfaction on the team. And because it's a wonderful place to work, to be able to work together as a team is, I think, it's quite unique, the work that we do together. So,
Dynamic too, and it requires very strong teamwork, right? Because of the urgency
and I've been an emergency nurse for over 30 years. I've loved it. It's pretty much my primary area that I've practiced in, and I love it. I have not seen the challenges we've ever had before as we are this year. It has been incredibly challenging and incredibly difficult for our frontline staff, both physicians and nurses, to stay and want to work there because of those challenges. So it is an incredibly difficult time right now that we're working through. And the only thing I can say that one of the benefits that we have and why I'm still here is our team, because we have an amazing emergency core network team, as well as all of our managers, directors, and physician leads at the sites. They work very well together with all of us as one huge team. And that is probably the only positive light that I have these days, is that team that's keeping me going. But for the front line who are working, they have so many other options to work. And that's one of the challenges. So we're losing people to work in settings that is easier.
Yeah, and we see that not just in nursing, but also in physicians as well, in emergency departments.
Yes, for sure.
And Craig, you mentioned access to primary care being one of the key areas. Is it access to primary care overall, or is it access to primary care in after hours, evenings, weekends? Do you see one being a bigger issue than the other?
I think that's a good point. It is, after hours access is important. In-person access is really important for many presentations. But we do continue to see patients that say, I didn't think I should be here, but I called my primary care provider and they could only see me in a month. So there is
There's multitude
it's layered for sure.
So it's access in terms of timely care if they already have physician attachment, and then it's also after hours or evenings, weekends type of things, as well as some people that don't have primary care physicians. But it does sound like I also hear from patients and families, they feel bad coming into emergency department because they don't feel like they have an alternative. And right now it seems like all roads sometimes lead to emergency department. And I think, Mary, you talked just in the beginning about there are alternatives that we have been successful in bringing up. And I know, for instance, Surrey's been quite successful with the urgent care near the hospital as well. So maybe, Craig, you can talk a little bit about that.
There is a Surrey Wally Urgent Primary Care Clinic, which has team members, nurse practitioners, and primary care physicians that are trying to see patients that are unattached, and also a component that is sort of more walk-in, or what they call episodic care. That center is being challenged with staffing, I would say. So we put in a pilot project where we staffed a part of that clinic with emergency physicians for the episodic or walk-in care, and that has been hugely successful. The community has really appreciated the ability to see a provider for timely care in person without an appointment. And what we've seen is that most of those patients, the vast majority, when we ask them, would have gone to emergency had they not been able to go there. So that's, I think, a very, very successful.
And you mentioned virtual versus some people really needing in-person care. And one of the solutions that we do have is virtual care that's readily available. What are some of the presentations in emergency department that you see, Craig, that you believe that should be more of that regular in-person connection will be more helpful?
Well, certainly anything that really needs timely care, I don't think. Obviously, if you have chest pain, shortness of breath, or things like that, you should be going to emergency. But there are a lot of things where you really need eyes on. I mean, I think of something as simple as a child with an earache. I'm not sure how you make a diagnosis of an ear infection unless you can actually look in the ear, and you can't do that virtually. So there, and it's lots of subtle presentations, like, see how fast you're breathing when you're sitting across from a patient, or what is the cadence of their speech, or are they out of breath, or little subtle cues that are important to understanding if this patient's really sick or not. So if you're, for example, and I'm not a primary care physician, but I can imagine if you're calling for, if you're in need of like a conversation around medication side effects or medication renew, or maybe it's a mental health wellness check, and you just need a conversation, I think that's really great. And really, you can do a lot of those things virtually. If you're in need of something's wrong physically, you need eyes on it. It probably needs. It would be better to have someone looking at it in person. Yeah.
Okay. And once you're, say, looked after in an emergency department, and sometimes whether some of the folks are okay and they're discharged home with just minor issues, and some people are admitted, and that's one of the patient groups that you talked about. And sometimes it's also quite frustrating on patients and families, not only difficult and challenging for emergency staff and physicians as well. So what's going on behind the scenes when people are admitted and they're waiting to be moved into their bed upstairs or inpatient unit? Maybe Mary, you can start.
Yeah, I can start. They usually have to have the physician hand over to either a most responsible physician, someone who is assigned to the site, and depending on what type of care they need, whether it's medical care versus surgical care versus cardiac, things like that. So there's a handover in physician. They often stay in the emergency department for at least 24 to sometimes 72 hours, if not longer, because of lack of capacity on the inpatient units. So there's a nurse assigned to take care of them. It could be the same one that was working with the patients earlier in the day, and now they're admitted. And so there's a whole number of documentation and forms that need to be completed to ensure their safety, from isolation precautions, making sure that they haven't traveled overseas as an example, so they don't have higher level infections, making sure we have screening questionnaires done by families and patients so we understand if they've got any challenges that we need to deal with in the inpatient environment. So lots of that kind of work. And then a lot of medical treatment orders that need to be done for their care through this journey in their admitted patient status. The emerge is a very chaotic place. It's not a nice place for patients to have it. They're very rarely in a room. Some of our new emerges may have a separate space for them. That's an actual closed room. But often they get pulled out of that and put into a hallway because there's someone that's more urgent that needs that space. So they can actually be put in back hallways these days. And that's very challenging for our patients and families. We also have a much increase in kind of, because of the frustration with waits, in people who get frustrated, and we have more aggression and more violence in our departments than I've ever seen before. So that's another issue that both patients and families as well as our staff have to deal with. And it can be a burden to make sure everybody's safe when that happens. And we've increased some security presence in a lot of our departments, which has been very helpful. Relational officers have been very helpful. But there's, of course, the more resources, the better at some of our sites. So, yeah.
Anything from your perspective, Craig?
Yeah, we always start with the premise that the best place for a patient to be once the decision is made, you need to be in hospital, is on the most appropriate ward, whether it's a regular medical ward, a mental health ward, intensive care unit, being looked after by an inpatient specialist. So we don't want anybody in the emergency department. We know that if you're stuck waiting for a bed overnight, as Mary said, emergency departments are very noisy places. You can't get sleep. You're constantly interrupted. You don't have easy access to bathrooms. So all those things contribute to potential problems, and we want to minimize. We want people to have the best care and avoid those kind of situations. And then one of the sort of unique challenges we've had, I think, recently in Fraser Health is, we used to rely on the family practice model or GP model, looking after patients in hospitals and for basic medical care. And then we transitioned over the last decade or so to a model of hospitalist medicine if you needed a general ward. And we have had challenges at several sites filling hospitalist medicine rota. And so emergency physicians are drawn a little bit more into looking after inpatient care, inpatients, which isn't really their area of expertise. So all these sort of challenges add to the stress and
the practice environment.
Practice environment challenge. Yeah.
And what's being done to, I guess, ensure that there's more timely movement of patients into the inpatient and to the most appropriate care, most responsible physician?
Well, there is a very clear process in the hospital of on the operational side, having regular bed meetings every day. We have site leaders in person on site, trying to make sure all patients who need to be discharged are actually discharged quickly, getting patients up to the wards as quickly as possible through lots and lots of meetings and conversations. So
our whole access and flow team is focused on that. The challenges we feel is that it's just keeps getting worse. It doesn't seem to be getting better.
And why do you think that is?
I think it's multifactorial for sure. Aging population, so we don't have enough long-term care facilities, so we have lots of long-term stay patients at some of our hospitals. Challenges with that. Challenges with staffing, not enough nurses, not enough physicians in all sectors. And so nurses are caring for more patients, so we can't do all the timely care that we need to do. In the emergency department especially like Craig said, there's no bathrooms, so it's much more challenging. So length of stay, that's the time that a patient will stay in a hospital. Our length of stay times sometimes are longer just because they're in the emergency environment with all of our challenges for a longer period of time. So other issues can develop for the patient before they even get to the inpatient unit. And it's noisy and it's chaotic, and it's we try and turn down the lights at night, but when a very sick patient comes in, the lights go on. So it's challenging all around.
I think sort of access to acute care beds and the number of acute care beds to the population, I think there's a difference in regionally within British Columbia, and I think Canada versus other countries, we don't have the number of acute care beds for the population, particularly in Fraser Health with the huge population growth that we see. So I don't think the resources have kept up to the demand. So.
And what would you think could be done differently now in terms of like the beds and those types of things will take time? So are there things that you see as solutions?
Well, we need to optimize the number of days a patient stays in the hospital is really impactful on the overall congestion. So if you can make that hospital stay more efficient, and even if you can decrease, if you take a site like Surrey, for example, the number of beds it has, if you decreased the average length of stay of all the admitted patients by just a half a day, you would get 40 extra beds just by that decreased stay multiplied by all the patients you have. So really making the stay efficient, making sure all the tests and consultations and all the investigations sort of get done in a quick way or as efficiently as possible would help. And then probably having a better transition back into community, back into primary care providers, care and knowing which ones and how we can hand off the remaining bits of care to community partners would be helpful.
Any other thoughts, Mary?
I think we need to make sure we're optimizing our skill mix in all units. So we've done an incredible amount of work in Emerge. I know there's some work starting, for example, on our medicine units. So optimizing team-based care there, making sure they have the right mix of RN, LPN, healthcare aide. Everyone has a role in on these units, and the more we can do to get patients up and moving and making sure they're eating, those can all be done by healthcare assistants, so the RNs can focus more on their higher level task of ensuring those patients are getting what they need to go home early. So I think really optimizing skill mix, a little bit is to do with our staff, our shortages, number one, our workforce. But I think really pushing forward to getting that really done in innovative ways. Using the technology we have at hand in a different way. I know at Eagle Ridge they're doing the virtual hospitalist program, which is coming out with some innovative ways. And as we move to our new Meditech Expanse, that's our electronic healthcare documentation system, once we move to that, I think there's a lot of opportunity there to do things differently than what we've done before. So I think there's that's some of the things we can do now, and even the use of more information for the public on the website in terms of how to access better care. I think there's opportunities there as well, and encouraging a more robust urgent care model in our UPCCs, our urgent care primary care centers. Some of them are becoming more robust, taking more same-day appointments, those kinds of things. That's really where we can make sure the patients are getting the right care in the right place at the right time.
You talked a lot about some of the solutions that we could look at internally as well as with digital. Are there other systems that you see from other parts of the world that you think that we could adopt and adapt with in our setting?
My brain is on virtual these days.
I would certainly say, to Mary's earlier point about urgent care model, so we do see in a lot of countries that urgent care works in concert with emergency departments in a much more coordinated fashion, and very, very often it is within the domain of emergency departments. So you'll have emergency staff working in urgent cares. That is not really the model in BC, but I do think when you have the same team members and you have the same ability to, same focus to see things quickly and make quick decisions, and it's all within your skill set to be able to treat the range of presentations that need time and care. I think that's a real opportunity in British Columbia to look at how we provide urgent care, maybe not urgent primary care, but urgent care. Lots of opportunity.
Yeah, and I just want to add to that. I think that is a really interesting model that, especially in the States, some of their U.S. hospitals are doing that, where they have a separate, what looks more like a clinic outside of the emerge department, but it is staffed by a physician or an NP and emergency type nurses. So we do have emergency nurses who go work in UPCCs, and that's one of our reasons where we are a little short, is they'll take a part-time line there or move completely, because it is similar to emergency work. It's urgent care, but it is also a little bit easier work. Yeah. So trying to build that model in Fraser where similar to the clinic at Surrey that we just spoke about earlier, where it is staffed by emergency physicians or nurses, and they see a lot of patients in a day. I think it's 70 or 80 in a 10-hour period, so it's a lot of people that are getting their urgent care needs right away. Yeah. My one concern is the episodic care of it. That is one concern. Yeah. But even if they can come back regularly, which they often do until we get our primary care model functioning in a more robust way, it might be a good interim solution in the next couple of years.
Yeah, and we see, thinking of other provinces in Canada and certainly the U.S., there are team members that we don't have in our emergencies. When I think of that specifically, I think of physician assistants. So that's a very strong model in many places where they're working as part of the team. They're sort of extenders. They have training to assess patients quickly and work with the nurses and physicians to provide additional care. And that would be, I think, a helpful.
Yeah, and I know we are talking about bringing physicians assistants in, so that will all support the practice and emerge for sure.
And you talked a little bit earlier about, when patients' families come to emerge, some of the expectations, and sometimes there's, I think, ways that they might be able to help the services that are being provided in emergency departments when they're visiting. Any specific advice? Are there things that patients' families can do ahead of time or during their visit that might be helpful for them and their care journey as well as for the team?
Absolutely. Bringing your family members' list of medications, if there's a list of medical problems, that's helpful. If you're being sent by your family doctor, bring the note the family doctor sent.
I can definitely give you some ideas when they're actually in the emergency department, because time for us is so important, because the ones who are really sick, we want to get to them soon. And when you have a queue or a lineup waiting for triage, the triage nurse does do a critical first look, but often some of the sicker patients have their symptoms masked. You can't tell. And so being ready with your care card, being ready, having your coat off, getting ready, knowing that you're going to be asked some questions by the triage nurse and have a blood pressure cuff put on your arm. Those minutes are valuable. Those few minutes that saves for all of those patients in the lineup is really important. So being ready to answer questions. And I think the other thing is our system is made on building on information from one team member to the next. So the patient or the family may be asked similar questions over and over again. But that is part of us ensuring that we're getting to the details of what they're here for and what we can do for them. So patience is really important from the public's perspective, and an understanding to know we are all trying our best to provide care, and things may take a little longer. Only because there are individuals. It's not first come, first served. It is individuals that are definitely needing care more urgently, and so we're having to deal with them first. Yeah. And if they have a question, just ask someone a question. Yeah, we're happy to answer.
I think the point that you mentioned about the system is built on, in a way, it's multifactorial kind of validation, right? Like, in a way, emergency departments are especially set up to reduce risk and potential emergency events. So sometimes I think people do get frustrated, or people feel as though they're being targeted if they're being asked, do you have alcohol intake or do you use substances? And they're answering that question, and then they're asked again and again. They feel like they're being targeted, or we don't trust the answers that people are providing. So I think your point, Mary, about the same question being asked multiple times, maybe, Craig, you can provide a little bit more in-depth about the rationale of why that takes place.
So there is always redundancy in the emergency department. You can imagine if only one person was assigned to asking the question one time, do you have any allergies? And a patient may have forgotten to tell that provider they have an allergy to some unusual drug. It slipped their mind. So we will always ask the question multiple times. We do not want to cause any harm. We want to make sure that you're treated as safely as possible. So yeah, we do ask lots of questions, often the same.
And I think I'll add, with our toxic drug crisis that started in 2016, we worked together on that way back then. We do have universal screening that we ask everyone about their substance use, alcohol, drug use as well, that it's not regulated. It's important information. We want to make sure people have the services they need, and if they need any support and help. So we're not targeting people. It's something we need to normalize as part of your clinical assessment. It's part of what we need to know to understand how to treat you better. That's really what we're doing.
Well, I know that both of you have worked in different settings in the emergency department in different roles as well. Is there one kind of patient or one experience that really touched your heart?
Oh, I've got one. So I'm going back to my role as a frontline emergency qualified RN at RCH Emerge. Most of my practice is at Royal Columbian Hospital, and I was dealing in the middle of the night with a trauma patient, and doing the C-spine precautions and talking to her while the physician was assessing the rest of her, and just speaking in a calm way, trying to reassure her and whatnot. A year later, she walked into our Emerge department, And she recognized my voice, and she came over to me and she said, "Oh my goodness, you were the nurse who was looking after me that night." And it is one of those moments that has really captured me and made me realize how important emergency nursing is for me. And the thing she said was, "You treated me with kindness, and I felt like I was in good hands." And I had my hands, of course, across our neck to ensure her cervical spine was stabilized, and so I was right over her talking to her while everything else was going on. And that was a really resounding moment for me in terms of why I'm still here.
Well, because for these emergency situations, it might be day-to-day work for our nurses and physicians, but it can be a life-changing event for patients and families.
I think what's so amazing about emergency medicine as providers is you have this opportunity, a window into somebody's most vulnerable moment, and that is a really special place, a special thing to witness, and you have the opportunity to make a huge difference. And I think of, you're asking what a particular case, I can think of really impactful conversations with, we're seeing a lot of mental health issues in adolescents and children, and if you take the time and really get into a good conversation, you can make a difference. I think of a teenager that I saw that was not living with his biologic parents, but in care, had a tremendous amount of anxiety about their situation, and worried about substance use issues, mental health issues. But when he got into it, it was really about the anxiety of whether this person's parents, who had their own substance use and mental health issues, whether all that was going to be genetically passed on, and they were destined to become like their parents. And taking that time and saying, that's not your story, that's not your journey, was really it was a very touching interaction.
Yeah, you have that privilege of having that kind of opportunity, as you said, of interacting with people when they're most vulnerable, but being able to have that kind of impact that could change their trajectory in health, mental health, and otherwise. So I asked this question to everyone. One last question, which is, what is the word that you would use to describe future of healthcare, and why?
Challenged, I would say. We have a system in the country which I think Canadians really hold on to and really believe strongly in universal health care, with aging population, complexity of disease, cost of investigations, treatment, the resources to support that system for everybody in a timely manner is very, very challenged. And how do we navigate what we hold as important and the system we want with what it costs and providing for everybody?
And I would say worried. I'm looking with the lens of our frontline nurses and providers. I'm worried that where we're going to go because of the challenging practice environment right now, and how are we going to keep those really, really highly educated folks, right? They really know their business, our emerge qualified RNs, LPNs, and our physicians. I'm worried. It is a difficult place to work right now.
Well, Mary and Craig, thank you so much for your leadership in navigating through very challenging and I think complex setting right now, and especially, as I said earlier, often all roads lead to emergency department right now, and we're seeing a lot of increase in complexity, burden of patient care, and burden of, I think, that responsibility on the people that are and the teams that are holding that responsibility. And without your leadership, it's difficult to have that team that you talked about that are working together to provide the best care possible. So thank you for providing some of those insights to our listeners today, and thank you again for your leadership role.
Thank you.
Thank you.
Join us next time as we continue to get to the heart of healthcare. Don't forget to rate and subscribe to this podcast. The Heart of It is produced by Fraser Health Communications and Public Affairs.